Over to you, sir.
A warm good evening to all of you. I think I am audible. You can hear me? Audible.
It's audible, sir.
Something wrong.
So you are audible, Batani.
This is okay.
Okay. Today we are actually gathered for the second neonac series. The first one by Dr. Deepak Lewis from Canada. And that time, last month we have about more than 100 delegates attended. So we are very happy. So with that background, we are starting the second talk on by the speaker other than one of the leading speaker, Dr. Manisha Kaushik. Today, this is second talk, and I think so many will be interested to join our this meeting. And we are really delighted and happy that our one of the encyclopedia in neonatology, Dr. Naveen has come to. Naveen has here to join us for his inaugural address. I need not introduce Dr. Naveen to anybody here because he's a well-known figure in the neonatology. He has got international as well as national awards. He has published so many papers. He understudied so many books have been published. And not only that, he's so humble and simple. That is the most important thing. And he has also helped any time when we talk to him for any of the. So, sir, on behalf of all the people here, I should say you not only deserve the handcuffing, but you deserve the salute of all the neonatologists, also pediatrician of all of Kerala as well as all of India. On behalf of all pediatricians, I welcome you, sir, to our gathering.
So,
And again, I must introduce our the guest speaker, Monica Kaushik. Kaushik, she did his MD from Chandigarh and DM from Amrita Institute, All India Institute of Medical Science, Delhi. And she has his FRCP now. She is the leading head of the Department of Neonatology in Emirates Hospital, UAE. And personally, Dr. Lynch has very good opinion about her, and even though I have not seen her, I know her. She is going to give a very interesting talk on a very unusual subject, unusual complications in common neonatology. This may be interested by all the people I see. On behalf of the IAP Kottayam, NNF Kottayam, I welcome Madam to this gathering. Thank you, Madam, for your esteemed presence. I welcome all the senior members, especially Dr. Sukumaran, Dr. Other members who are present here, and I welcome our esteemed president of Kottayam IAP, Dr. Balajinder, secretary our Sumida, Dr. Sahila, secretary, and other members who are gathered here. And the person behind is Dr. Lins for all these interesting didactic lectures. All other postgraduates are also welcome. Because of the time lacking, I am signing out. Thank you to everybody. Thank you all. Dr. Lins.
Thank you, Patani sir. Now I invite Dr. Naveen sir for the inaugural address. Dr. Naveen doesn't need much introduction, and it's actually I am a big fan of Dr. Naveen. Not only me, almost all the budding neonatologists are a big fan of Dr. Naveen. It's not because of his knowledge or anything. It's because of his simplicity. We can actually easily access Naveen sir at any time. So over to you, Dr. Naveen, for the inaugural address.
Vince, thank you so much for inviting. When you said it is for Monica, I was so excited because Monica is a personal friend for maybe now, I don't know, I don't want to tell number of years, otherwise you would probably guess Monica's age. She is a very charming lady and you would not want to guess her age. But she's a wonderful friend and very brilliantly trained. This is not because she's in front of me. It doesn't take anything to guess that if you have post-graduations from best institutes of country like AIMS and PGI, and then after seeing that, single-handedly, she has set up many units and taken them to great heights in a country which probably did not see high quality neonatology till Monica went there many, many years back. Personally, of course, Monica and myself are very close friends. We have had the fortune of staying with her at her home and enjoying her hospitality in the morning, a short conversation, and you can see her professional commitment despite of what we are seeing in Dubai. Her personal and home were affected by the floods, and I was going to ask her how she's going to be able to manage, but you can see that there is not a hitch in going ahead with the professional commitment. The topic is of great interest, and Monica herself has contributed in the chapters of our book in addressing some of the complications. I'm sure we'll hear stories from her own experiences and some from literature. Over to you, Monica. Thank you. Good to see you.
Thank you. Thank you so much. I'm really humbled to have been listening something from Naveen. And as Lynn said, everybody is fan of Naveen, and for many, many reasons, for sure. And I'm a great fan. Having said that, I'm so sorry that I will not be presenting the topic which was given to me because of the fact that there was rain. And I had prepared in my hospital thing, and I was supposed to be presenting from there, and I couldn't go because of the rain. I tried my best today, and I also tried people to send from there, but they couldn't. So please forgive me for that. But I will be presenting to you interesting cases. So my topic is a little bit twisted of normal antenatal, history when you get an unusual cases. So they're interesting cases, but the one I wanted to really present was a bit different, and I'm sure sometimes later I would get that opportunity to present that. Why is it not going full screen? So I hope the screen is clear to everybody.
It's clear.
Yeah. So I'm talking about unusual complications of a usual antenatal course. So we have few cases. Just stop me if the time doesn't permit. These are all our cases, and they're very interesting. So a term baby with birth weight of 3.7 kg was delivered by semi-elective cesarean because of the failure to progress. And the antenatal scans, as I told, was absolutely normal. There was no risk factor for sepsis. The blood bookings which were done antenatally were all normal. Baby cried immediately after birth, and Apgar sign was 6 and 8. However, baby needed some 90% to maintain the saturation. The oxygen requirement was quite high, and hence was intubated and transferred to the NICU. Umbilical lines were inserted because baby looked quite sick, and baby was hang on ventilator with PCAC mode of 25/5. Inspiratory time was 0.36. Rate of 40, and FiO2 still required 50 to 60% to begin with. And when we looked at which we do for all our babies, the pre-ductal sats and the post-ductal sats, there was a difference of more than 10%. So pre-ductal sat was 90 and post-ductal was 79%. On the blood gas showed a pH of 7.33 with PCO2 normal and base excess -3. The blood pressure was normal. So if you look at the X-ray, which looked almost okay, except for a little bit of cardiomegaly, you can say, and a little bit of like a TTNB kind of a picture. So because of the cardiomegaly, we did echo for the baby, and what we saw is superior vena cava was dilated, and the inferior vena cava was dilated. If you see this, there was a tricuspid regurg with a little bit of right ventricular systolic dysfunctions. Oh, sorry. So this is what we could see in the right ventricular dilatation. The other view, which showed kind of a shunt, which is going across, and the shunt is through the duct, and the previous one shunt is through the PDA, through the foramen ovale. So this is how it looked like, overall picture with the right dilatation. And then when we did an ultrasound of the brain, it also was showing a resistive index, which we calculated of 0.7. So one of our, and if you see, there was a lot of noise, which we could see here on the Doppler, which we did on the brain. And some of us thought of, can we auscultate the skull, because it looks very noisy blood circulation across the brain. And what we could hear was bruit over the anterior fontanelle. So this gave us a clue, and this I'm just telling you because this was not done on the same day that you thought about it. We struggled with the baby and we couldn't get to the diagnosis because so we were going back and forth, and then this came into our mind that let's do the ultrasound. And when we saw this noise, we heard the bruit over the head of the anterior fontanelle. So whenever we get a PPHN unexplained, we must look at this bruit on the scalp or the liver. That's the message we got from this case. Now the case 2. So this was a very interesting case, and this is a preterm baby born to at 34 plus 2 weeks, and the birth weight was 2.7. Born to a gravida 2 para 0. Antenatal checks again was normal. Anomaly scan was normal. Mom was just on Eltroxin and metformin. And just one day prior to delivery, there was a notice of a decreased fetal movements. And second day, next day, when obstetrician saw, she saw a flat CTG, and so the mother was transferred to our hospital, and our hospital also saw a flat CTG, and hence an emergency cesarean was done. Baby was delivered within the next 30 minutes. So what was seen was a blood mixed liquor, grade 3 thick foul smelling meconium. Abruptio was seen because there was a lot of fresh blood. Baby was totally covered with blood and dry, thick and viscous meconium. At birth, there was no heart rate or breathing, and initial PPV was done, which was followed by intubation because the baby did not respond. After the intubation, the baby's heart rate picked up, and we did not require to give any cardiac compression. Apgar assigned was 0, 6, and 7 at 1, 5, and 10 minutes. The cord pH showed 7.22 with bicarb of 6. 25 ml of blood was aspirated from the stomach. However, soon the baby was showing a spontaneous movements, and eye opening was present. Baby did require ventilation because was not picking on the saturation, not because there was not a very low respiratory effort. Requirement of FiO2 was 30%. And also the baby developed hypertension, for which we had to start dopamine followed by dobutamine and norepinephrine, and even we had to go for hydrocortisone. Seeing this kind of a course of the baby, and seeing the X-ray, which also showed a little bit of cardiomegaly, we did an echo, which showed a severe PPHN. The pulmonary pressures were near systemic pressures. There was a PDA of 4 millimeter, ASD of 6 millimeter, and there was a right ventricle which was dilated. As we noted, there was a metabolic acidosis, and there was a high lactate of base excess of -5 to 8 and lactate of 4 to 8. Initial liver and renal functions showed a OT of quite high, 2,685. PT was a bit high. Creatinine was 1.23, and the urine output was around 1 ml per kg per day. We looked at the coagulogram, which showed a INR of 3.49 and platelets were 108. We all were contemplating whether definitely there was a perinatal asphyxia. Should we do a hypothermia treatment for this baby or not? And minded, the baby was also 34 plus 2 weaker and didn't really fulfill the full criteria of, starting a therapeutic hypothermia. So we had a lot of discussions on it. We also went ahead and did a cranial ultrasound, which showed a normal resistive index of 0.7. So all we decided not to go for therapeutic hypothermia. However, in few days, what we saw was there was a worsening of the renal functions over the next few days. Creatinine had increased to 2.7 and urine output remained around 1 ml per kg. We had to, it went a bit low, so we had to treat with furosemide infusion and albumin with fluid restrictions. Slowly with this, there was an improvement over next few days. There was a thrombocytopenia which persisted and coagulation abnormalities persisted, which required platelet transfusions, FFPs, and cryos. Gradually, the liver functions improved, but then again began to worsen. The lactate all the time was fluctuating and remained high for a very long time. Even the base excess was fluctuating and remained high for a very long time. The pulmonary pressures always remained near the systemic and did not show much improvement. So we repeated the echocardiogram, which showed ASD, large PDA, and the shunt was left to right. The right ventricle was dilated. And when we repeated the chest X-ray, what it showed was a dilated kind of heart, and there was a pulmonary edema. So cardiomegaly with pulmonary edema. And because the renal functions were deteriorating, so we did renal ultrasound scans, which showed reversal flow in the renal vessels. So we were really facing a challenge of, on one hand, pulmonary pressures are high, and on the other hand, we have a pulmonary edema and large PDA with left to right shunt. The renal functions were slow to recover in spite of all the systemically, whatever we are giving a support to the baby, and the liver functions were worsening. So the bone marrow functions in the form of the platelets and the cells were also slow to recover. So then we were not able to know what's going on and what could have been the issue. And someone suggested this kind of heart and this kind of lungs which are going bad. Let's go and ahead and do a CT chest. So we did a CT chest with contrast, and what we found was this. So anybody would guess what is it? So it's a severe coarctation of aorta. So, and this was missed in our echos, which were repeated several times. So these take-home messages are, whenever you have an unexplained cause of like asphyxia, pulmonary hypertension, you must think of out of the box, and you must look at the other clues which you are getting, like in the first case, vein of Gallen deformity, which can mimic PPHN. And if we don't fix it and diagnose it in time, we may have a high mortality. And what we was a clue in this case was retrograde flow in the aorta, which was a very important sign, which we picked up after the third echo. And that is the time when we thought of listening, doing an ultrasound brain, looking at those, and then listening to the bruit over the anterior fontanelle. And other thing like coarctation of aorta can masquerade as pulmonary hypertension, especially when you have not a real picture of pulmonary hypertension, and we have a mixed things of other things coming up. So these were two very interesting cases, and questions still remains, and there might be a lot of debate on it, whether when we have a spontaneous movements and eye openings, a little bit of respiratory efforts, would you cool this baby? And another thing which was important to talk about was, is all the thing in the second case was like ductal stealing was causing the problem. And if ductal stealing was causing the problem, which was to some extent, Should we have treated the PDA? Then answer was, of course not, because if we in such cases where there was pulmonary hypertension, and I believe that pulmonary hypertension here was with right heart dysfunction. So in this case, if we want to treat PDA, it can actually worsen the pulmonary hypertension. Now, so another debate which comes in this case is, should we treat the pulmonary hypertension then? Then what would have happened was, if we would have treated the pulmonary hypertension in such kind of case, then it could have made a ductal steal worse. So these are the dilemmas. We just, not that we had an issue how to diagnose these cases, but also the treatment of these cases would be not simple, as we must know, if we treat something, we might worsen the other thing. So just not if we see pulmonary hypertension, go and start nitric oxide, sildenafil, or milrinone or whatever. And the moment you see a PDA and you see left to right flow with cardiomegaly and pulmonary edema, don't just go and start Brufen or indomethacin to close the PDA, because it may, in this kind of situation, may cause worsening of the pulmonary hypertension. So these are the very nice cases which we had. The third case, in the antenatal period, the mom's history was that she was a gravida 2 with para 1. Again, the booking bloods were normal. The NPT tests were normal. We did this NPT test because also the previous baby had Williams syndrome, which was diagnosed at 18 months of age. There was no other concern. So at 38 weeks, the baby was having a 2.2 kg of weight. There was a small first gestational age, and elective cesarean was done because of the previous history and the SGA, and the moms wanted it. The baby cried immediately, so did not need any active resuscitation. But what was noted by the nurse, that she felt that there was some nasal block. So she tried to do the suction, and when she tried to go a bit deep, she was finding it difficult to go more deeper and the right side of the nose. We admitted the baby in the NICU at 6 hours of age. Because the baby was fine, so was transferred to the mom, and so this was the only thing finding which the nurse had seen and which she revealed later on. But at 6 hours of age, when another nurse, when checking on the baby with the mom, she found that the baby was having difficulty in breathing. And since with that, the baby was admitted to the NICU, and the saturations at admission was 87%, and there was a mild distress. So we started baby on the high flow, 5 liters per minute with 30% of oxygen. The blood gas was performed, which showed that pH was 7.2 with CO2 of 59.5, bicarb was 22.9, and base excess was minus 6.64. So with the admission protocol we did an X-ray, and this is what we saw in the X-ray. A little bit of, again, cardiomegaly, little bit, and there was a thymic shadow, and the lung fields were almost looking normal. So on day 2, the baby was much settled on high flow, so we could decrease the oxygen from 30 to 21%, and we also saw the improvement in the blood gas. However, that nurse who was there in the delivery room, she said she had a problem in passing the NG tube through the right side of the nose. So she tried passing the NG tube again, which was a difficulty. And on the left side also, the size 6 could not go, and we had to go on lower size of the NG tube on the left side. And this made us to have an urgent ENT review, because we did suspect a choanal stenosis. It wasn't atresia for sure, but we thought of choanal stenosis because it was a term baby, and one side it's not going, and the second side, very small NG tube is going. And ENT came and examined, and he found the same, and he asked for imaging PNS and asked us to continue the same support. With the same support, there was a worsening, and on day 3-4, the requirement had gone up for the oxygen, and the carbon dioxide requirement, carbon dioxide accumulation also increased, and the pH dropped to 7.19 with CO2 rising up to 69. And hence, for the respiratory acidosis, we had to intubate the baby and ventilate the baby. As I showed that there was a little bit of cardiomegaly on the first X-ray, and on the repeat X-ray also there was an enlarged heart shadow, and hence we did an echo, which we also did because of the worsening of the ventilation requirement. And what we saw was moderate to severe pulmonary hypertension, small PDA, and right ventricular dilatation. On ventilator, when the baby was put on the ventilator, the blood gas did improve. There was no hypotension, so there was no requirement of inotropes. And the oxygen requirement was quite moderate, only 21 to 30%. Because of this pulmonary pressure being high, because the oxygen requirement was not much, and the ventilator requirement was not much, we decided not to start on nitric oxide, but to start on sildenafil. And this is how the X-ray looked, the cardiomegaly, and the little bit of cardiomegaly improved after sildenafil. The another thing which we were facing was the choanal stenosis. So we did a CT, PNS, which did confirm choanal narrowing. There was a query on the pyriform for some narrowing. Baby was stable, so we did start discussing on whether we need to do a choanal surgery on this baby. The ENT asked for more of a MR brain and PNS, and again the echo was repeated, which showed on sildenafil pulmonary hypertension was improving. Right ventricle still remained dilated. Now, why in this patient we had a pulmonary hypertension? This was a question, whether we should do surgery or we should not do surgery. This was another question for the thing. So we had a relook at the imaging on the PNS, and what we saw was a mild choanal stenosis, and even the pyriform aperture was having a stenosis. So this is how a pyriform aperture should look like normal development, but if it is stenosis, this is how it will be. It will be much smaller, and this was the case in our baby. So we had pyriform stenosis and choanal stenosis more on the right side, if you see, and left side was less. So we had multidisciplinary team meeting, a Mayo consultation was taken. We have a Mayo, very good ENT in the Mayo Clinic in Abu Dhabi. So they were kind enough to have come with us for the MDT consultation. What we found in day 7 to 10, they were stable on ventilation. Blood gases were fine. Eco-wise, pulmonary hypertension was better, and right ventricle was still dilated. And when we did a multidisciplinary team, which was involving the radiologist, ENT, and neonatologist, they said, let's go for a trial to insert a bilateral nasopharyngeal airway and await the growth of the nasal cavity. So also there was a lot of edema because multiple times the NG tube was tried to be inserted. So local and systemic steroids to ease the edema around the choanae was decided on, and insertion of nasopharyngeal airway in the theater was done. So after doing that, we tried to extubate the baby to the CPAP, and what happened after extubation was that there was an edema which had increased, and there was oliguria which had come up, and we had to start on diuretics and fluid restrictions post-op period. We extubated to nasal CPAP via the nasopharyngeal airway. We put the baby on a PEEP of 8 and 30% of oxygen. And we had to do a regular suction on the NP airways. The baby remained stable. Need for oxygen was better. And the echo repeat showed a mild hypertension, moderate TR with gradient of 35 to 40. And the dilatation of right atria and the right ventricle was still hypertrophic. So this when, if we look at the echo, the X-ray, it was also showing in cardiomegaly. So we were all the time having a dilatation of the right side atria, ventricle, and cardiomegaly on the X-ray. Baby actually became sicker. If you see, the cardiomegaly became worsened. So there was a lot of edema, and we tried to change to soft and nasopharyngeal airway. Baby did not tolerate. There was edema, bleeding, secretions, and baby had to be actually re-intubated. Again, we had to take a second opinion from IOS clinic, ENT, and radiologist to say that, ask whether this pyriform fossa stenosis, how's it? Because normally the pyriform fossa should be more than 5.7, and here it was 5. Choanal stenosis was mild. There was a point sinus hypoplasia. There was a narrow anterior nasal apertures. And because of it wasn't so severe, they said whether contemplating whether we should do surgery or we should do a conservative again with the nasopharyngeal airway. We were not having a clear idea, why is the baby needing oxygen 30% and above? Why is this pulmonary hypertension there? And is it a choanal atresia, pyriform fossa stenosis really so severe that we need to do something to do a surgery? Is it really the cause? As we said, nasal pyriform fossa stenosis 5 millimeter and bilateral, it was bilateral, right more than left choanal stenosis. And this was leading definitely to a upper airway obstruction. The second thing which we were dealing with and were facing problem was respiratory distress with oxygen requirement around 30%. And we were looking at what could be the cause for this persistent issue. So possibly we were dealing with a combination of cardiac cause, atelectasis, and residual pulmonary hypertension. The X-ray was showing cardiomegaly with evidence of pulmonary edema, and echo, which we did 4 times, was structurally showing us a normal echo, except for just a pulmonary hypertension. And this pulmonary hypertension was improving on sildenafil. So way forward, we revisited the history and investigations. We again had a multidisciplinary team. We looked at the CT, PNS, and MRI, which did confirm the nasal pyriform fossa stenosis on the MRI from Mayo Clinic. And multiple X-rays showed us X-ray lungs were normal, only there was a cardiomegaly which was persisting. So now we needed more cardiologists to chip in to say what's the reason of this cardiomegaly. And some of us suggested, could it be anomalous venous connections, which we are missing, 4 times of echo structures being normal. So it was insisted to do an echo again by 2 separate different cardiologists this time. And when we did the 5th echo, we could establish the diagnosis. So the 5th echo was done, which showed that the IVC returned to right atria. There is a pulmonary venous drainage to the IVC, and 3 pulmonary veins were returning to the left atria. And this explained us the right atria being dilated and the problems. They were second-term AST with left to right shunt measuring around 7 millimeter and moderate TR with gradient of 60 millimeter of mercury. So we did a follow-up CT MRI chest under contrast, which showed us right lower lobe of the lung receiving the aberrant branch from the celiac trunk. And this was consistent with anomalous systemic arterial supply. So here we were dealing with something little more complex, and right lower pulmonary vein was, as we saw in the echo, was draining to IVC with engorgement of the hepatic veins. And so we were dealing with partial anomalous pulmonary venous connection. So what we were dealing now was partial anomalous pulmonary venous connection of the right lower lobe, anomalous systemic arterial supply of the right lower lobe. So we are dealing with a scimitar syndrome. So the question is, why you suspect, in spite of the 4 echos are normal, that we are dealing with this? And the answer would be definitely because the other things were unexplainable, and sometimes initially it might become difficult to pick up, especially a partial, because it's not a total abnormality, and we can miss the partial anomalous connections. And I don't know if any of you would have been managing it differently, but we tried our best to have a multidisciplinary team come into picture, and anybody would have, whether would have managed the piriform fossa stenosis differently here. So we can discuss that. Do we have time for the last case?
Yes, ma'am. We have time till 8:45.
Okay. So another case, we have a 36-week, 2.45 kg newborn born by emergency cesarean. Antenatal history was like she was booked and was followed in one hospital till 3rd trimester. There was she followed like late in the 3rd trimester. So that's the reason there was no anomaly scan done. And the late scans which were done at 34 weeks showed no polyhydramnios, no placental abnormality, but query right effusion. Maternal history of preeclampsia, no GDM, no fever, no prolonged rupture of membrane or chorioamnionitis. Torch was not available. So the baby was born limp and heart rate was less than 100. So we had to start positive pressure ventilation. In view of severe respiratory distress, we had to intubate the baby there and then. Saturations did not improve in the delivery room in spite of 100% oxygen. Chest expansion was not adequate on the right side, and air entry was reduced bilaterally, more on the right side. So the blood gas later, which was done in the delivery room itself, showed a pH of 6.8, CO2 of 79, and PO2 of 50, and bicarb of 10. So possibilities here, because what we were seeing was that chest expansion was not adequate on the right side, and air entry was reduced bilaterally, more on the right side. So definitely, because we had given positive pressure ventilation, because we had intubated, we will think about pneumothorax. And antenatally, because there was a query of pleural effusion, we did think of pleural effusion. The other thing which came in mind was, could it be a pulmonary hypoplasia or mass in the lungs? So because baby was not improving, so in the delivery room itself, we had to ask for a X-ray, and because when we did the red light test, we couldn't see the pneumothorax. So what we saw in the imaging was there was a right whiteout lung, suggestive of excessive right pleural effusion, and it is actually pushing the mediastinum to the left. And we had put the ET2 and G2, which was in thing. In the delivery room itself, we had inserted an umbilical catheter thinking the baby is sick and might require fluids because the baby is not improving. However, what we saw was that umbilical catheter was malpositioned. So what we thought was right excessive right pleural effusion and a malpositioned umbilical catheter. So we did a bedside ultrasound, and what we found that in the bedside ultrasound, what we found was significant pleural effusion on the right side, all R1, R2, and R3 zones. Underlying lung was collapsed, and diameter of the deepest pocket was 2.9 centimeter. And the left side also, there was a pleural effusion, which was mild to moderate in annual L2 area and minimal in the L3 zone. There were prominent B lines, and right-sided pleural tapping had to be done to make the baby stable. And we aspirated 45 ml of transudate fluids and ordered for FFP. Later on, when we repeated the chest ultrasound in the NICU, we found that right-sided pleural effusion reduced, and the deepest pocket diameter was 1.3 now. Lung expansion was better, prominent B lines were there. And left side, because we had not drained, so it was showing the same mild to moderate pleural effusion with prominent B lines. So we had to, because baby in the delivery room was not getting better, so we had to do, as I said, aspiration there only, where we had to drain 45 ml. And what we saw there, that it was a straw colored fluid. There was no pus, there was no pneumothorax, there was no blood when we drained the fluid. And definitely after draining, we did see improvement in the saturation. And so we had to shift the baby NICU on the ventilator support. So we shifted the baby with the diagnosis of pleural effusion bilateral and X-ray showing right-sided pleural effusion with the obliteration of the costophrenic angles. So when we had sent the pleural fluid for investigations, what we saw was on the first day, the color was yellow, appearance was clear, the nucleated cells were 3,309 high, and the lymphocytes were high. And because the lymphocytes were high, we thought of like are we dealing with the chyle? So we had sent triglyceride level of the fluid, which came 61. Cholesterol in the fluid came 43 and protein 3.4. So these were pretty not going in favor of chylothorax though. So we did made a diagnosis of because cholesterol and the triglycerides were normal, only lymphocytes were high, and it was bilateral. So we thought of congenital pleural effusion. Because of the high WBC and the lymphocytes, we thought of infective pathology. Could it be viral? And and also if there is something else, we have to look for fluid in other cavities. So we did an ultrasound chest, abdomen, and echo. So bilateral pleural effusion with moderate ascites and mild pericardial effusion was seen. So was it, would we label this as only pleural effusion, or would we label it as hydrops now? So with the echo, as I said, what we saw was there was a severe left ventricular dysfunction, extremely low left ventricular output, significant mitral regurgitation with left ventricular dysfunction and high afterload. IVC was flat, and there was a dilated PA and RV. PDA was quite tiny with bidirectional shunt. PFO was there with left to right shunt, and aorta was normal. Pulmonary veins drained in left atria. Pleural effusion was seen, and mild pericardial effusion. So the impression was left ventricular dysfunction with pulmonary hypertension. So to make a diagnosis of hydrops, we should have either a two cavity involvement like a pleural, pericardial, or abdominal. And if only one cavity is involved, then we have to have an asarca where skin edema should be more than 5. And there should be a placental edema. Placental thickness should be more than 4 centimeter in the second trimester and more than 6 centimeter in the third trimester. And there should be a history of polyhydramnios. So our baby did fit into hydrops. And when we think about this, we think about pleural effusion in the neonates. We think about hydrops. We think about chylothorax, congestive heart failure, and some syndrome. And then later on, if we would have seen pleural effusion, we think of extravasation, which we should always think about our misplaced peak lines, UVCs, and sometimes the OG tube piercing when we put it by force and milk going through the OG to the pleural space. And then sometimes we do surgically acquired pleural effusion or empyema. So now, are we dealing with chylothorax? We had that in mind. So because of the fact that we had lymphocytes quite high in the case. But to make a diagnosis of chylothorax, we should also have triglyceride more than 110. So whenever you have a triglyceride more than 110, it is less than 1% chance of not being a chylous. If we have a triglyceride less than 50, then we have less than 5% chance of being chylous. If we have triglyceride 55 to 110, then we have to go for lipoprotein electrophoresis. Now, in our case, criteria didn't meet because we had triglyceride of not more than 110, and they were less. Even the cholesterol was less. And if we look at the fluid to serum triglyceride ratio, which should be more than 1, it was 0.35 in our case. And fluid to serum cholesterol was 0.47. So the Light's criteria for exudate is fluid serum protein more than 0.5, and serum LDH should be more than 0.6, and fluid LDH more than 2.3 of the serum. So it wasn't coming into exudate, it wasn't coming in the chylus. So because of the reaccumulation of the pleural fluid, and we still had suspicion that it could be chylothorax, we were sending the whenever we were draining the pleural fluid, we were sending for the investigations, and every time the lymphocytes were remaining quite high. And then the next last few reports of the pleural fluid did show that triglycerides were 343, and the fluid to serum triglyceride had increased, and fluid serum cholesterol also increased, which made us to think that yes, this is the criteria which we met. But the NICU stay for this baby was for 2 months. We also made another way to diagnose that we started giving milk, and the pleural effusion increased. We made the baby NPO, the pleural effusion decreased. So this also made our diagnosis quite made us go towards the diagnosis. We did send for the torch parvo karyotyping, which was negative, and initial which chylothorax criteria not met, we did this way. And so when we fed with the milk, the output increased, and that's the time when we had sent for the investigations that we did see the triglyceride increased. And then we started the baby on monogen, which is milk specifically given for babies with the chylothorax. And for some time we had to give even TPN, and this made our drain to decrease, and there was no reaccumulation. The time which we had to put this tube in was 35 days, and the time where the baby required a ventilation was 40 days, and the resolution of chylothorax took 32 days. So how did we treat was by the draining the thing, keeping with NPO, and later on starting MCT-rich formula, and we didn't require octreotide in this case. So when we talk about chylothorax, most common cause of pleural effusion in the neonates, it's due to the leakage of lymphatic fluid from the thoracic lymphatic duct. and respiratory distress is there, and babies might require resuscitation. How do we diagnose? By when the counts of the WBC is more than 1,000 in the pleural fluid, and 70 to 80% of them are lymphocytes. When we feed them, the triglyceride is more than 110, and the chylothorax could be congenital, it could be traumatic, and it could be non-traumatic. Males are more affected than the females, and overall it's 1:2,000 to 24,000 live bonds have this. And as we know that the thoracic duct, lymphatic duct is on the right side, and hence that makes the right-sided more common because the right mediastinum location of the thoracic duct. So to sum a little bit, going to the anatomy, that we know that this thoracic duct is dorsal to the aorta and ventral to the vertebrae, and its cisterna chyli is at L2 to L3 levels, retroperitoneal right side, and at T5 vertebrae, from right side, the thoracic duct crosses to the left side, and it returns to the lymph to vascular system by emptying to the venous system, and the junction of left internal jugular and the subclavian vein where it enters. So this is the thoracic duct anatomy, which we must know to understand it. So what would be the clinical effect if we have a congenital chylothorax? Antenatal effects would be that you may be having antenatally diagnosed pleural effusions. It may also, if the pleural effusion is very big and from very early on, it may have a pressure effect to cause pulmonary hypoplasia. And because there will be a loss of proteins, there might be an interstitial pressure which will be increased. And that's the reason we will get a baby with hydrops patellis. And that was the reason we had the baby with hydrops patellis with pericardial effusion, ascites, and pleural effusion. So what would be the postnatal effect? Definitely when the baby is born, baby will not be able to ventilate properly, and inadequate ventilation would be a issue, and we might need to do a thoracocentesis, and this pleural drainage may be prolonged. And when you are going on for a very prolonged thoracocentesis, you will lose fluids, you will lose electrolytes, and you may land up in a hypovolemia, dyselectrolytemia. You will lose protein and fat if you are not vigilant enough to replace it by TPN or by the feed, and you might end up in a nutritional depletion. And we said that pleural effusion in the chylothorax has a lot of lymphocytes, so you are continuously losing these lymphocytes when you're draining this fluid, and this may cause immunodeficiency, and this will increase the risk of infections. So the overall prognosis for these cases, mortality is 30%, and if you have hydrops, the mortality goes quite high. And what makes the poor prognosis is if you have hydrops, and if you have a baby which is less than 34 weeks, and if this was going on for a long time and resulted in pulmonary hypoplasia, definitely the prognosis is poor. And if both the sides, the severity of pleural effusion is very high, then the prognosis is going to be poor. And along with that, if we have associated other defects, then that would make the prognosis poor. So why do we give MCTs in chylothorax? Because hydrolysis of MCT is faster, and it doesn't require bile salt or lipase. It is absorbed into the enterocytes, and there is no re-esterification. Directly it gets absorbed into the portal vein, and it gets absorbed much faster than the LCT, long chain triglycerides. And you don't need carnitine to metabolize in the liver. And what is available here with us is monogen and enfaport MCT. So these are the things which you will be using for our babies. Because here, if you see, if you're giving long chain fatty acids, there is esterification, there's a triglyceride, beta, and there is a formation of chylomicrons and lymphatic system. So you need all this to get the long chain triglyceride to get absorbed, whereas medium chain fatty acids directly gets absorbed. So when you also have an entity called a pseudochylothorax, where when you want to differentiate between chylothorax and a pseudochylothorax, the triglycerides would be less in pseudochylothorax, and cholesterol will be high in pseudochylothorax. And this is what was happening initially in our baby, but over a period of time, we did realize that it went into category of chylothorax. Also, the glucose is much lower in chylothorax, and it's much okay in the higher in the chylothorax. Vis-a-vis, if we look at empyema, definitely it will be a very there will be no triglycerides or cholesterol, and empyema you will have more of neutrophils in your thing, and you will have more LDH, and pH will be less than 7.2. So this is how you will differentiate between empyema, and empyema is also simple and complicated, chylothorax and pseudochylothorax. So we must know how to differentiate, and when we have a confusion, as I said, where we should always have a high suspicion, and you will see that all these cases we had to have a high suspicion to make a diagnosis. Antenatally, if they are diagnosed much early on, you can have an exit procedure where endotracheal intubation, gentle ventilation, and little aspiration is done before cutting the cord. Octreotide, I would say, though we didn't require in our baby, but it is a very commonly used medical treatment for chylothorax. And we all know that it is a growth hormone inhibiting hormone, and somatostatin is a growth hormone inhibiting hormone, and octreotide is a synthetic analog of this somatostatin, which has a longer half-life. So when we start it, we start with a continuous IV infusion. We start with 1 microgram per kg per hour, and we keep on seeing the result, and we can increase and go maximum up to 10 microgram per kg per hour. We should look at the complications like a local reaction at injection site. Also, there could be a complication of vomiting, diarrhea, abdominal discomfort. And whenever you start octreotide, we should see that chyle production decreases significantly within 24 hours, and effective in 47% of the cases. The side effects are only in 14% of the cases. So how does it act? It acts by blocking GH release, and this depressed insulin secretion and lymph fluid excretion by reducing the splanchnic blood flow. Also, what it does is that it does have a mild vasoconstriction in the arterial and lymphatic gut vessels, and by that mechanism, it decreases the hepatic venous flow and splanchnic flow, so that the chyle formation decreases, and it also causes a decrease in intestinal secretion of electrolytes and water. So it's a very good drug. However, sometimes it doesn't give a full result, and we might have to go for surgical treatment, and which includes you may have to go for a pleurodesis, you may go for thoracic duct ligation, thoracic duct embolism, pleuroperitoneal shunt, diaphragmatic fenestration, and sometimes you have to go for SVC, thrombectomy, and lymphovenous anastomosis. So these are the different ways where you can manage. Antenatally, you can do workup, genetic workup, pleurodesis, thoracoamniotic shunts. At birth, you can resuscitate, ventilate, and pleural drain can be given. As I said, diagnosis is made by pleural tap, which shows WBCs more than 1,000, lymphocytes more than 70%, and triglycerides being high, cholesterol being low. And when you feed the babies, it makes a triglyceride go high, chyle to be produced more, and that establishes the diagnosis. So we need to look at the fluid loss, protein loss, immunoglobulin loss, and plasma factors. And we need to give MCT formula, and sometimes we have to give TPN. And in resistant cases, we give octreotide.
Ma'am,
think-
actually, your time is up. Can we?
We are just finishing.
Yeah.
So take-home messages is Chylothax cream present as high drops. It becomes an neonatal emergency. We need to have a skilled personnel to do resuscitation and pleural tapping. And how do we diagnose? We already talked about. And always remember, chyle feeding may increase the chyle. And octreotide can be used in the resistant cases. So what are the diagnostic dilemmas in chylothorax? We can see through our case. How do we dietary manage? We can see through this case. And what are the medical treatments and surgical options? And what are the causes of chylothorax? Thank you.
Thank you, ma'am. Thank you for that valuable presentation. And now the topic is open for any discussion.
I'll pause share, yeah.
So if there are no queries, we will just wind up the session. I will just hand over to Dr. Sumita for the vote of thanks. Sumita, are you here? Sumita, you are not audible.
Am I audible?
Yeah, now you are audible.
Thank you, Lens. Just before I start off with a vote of thanks, just a query to our speaker and to the attendees. For chylothorax, what are the preparations that is locally available? Is there anything that is easily procured?
Ma'am?
I think everything is available. Arlene, you can tell, but I think everything is available locally because I know we have availability of MCT, right? Formulas available. Like we have monogen,
and support. We tried getting progesterone once, and there is the skim milk preparation also that we sometimes use. It's just a sort of indigenous preparation, and I think once it got published in IP also, where the skim milk powder is taken, some coconut oil and sugar is added, and that is also sort of locally used at times. Linz, any comments on that?
Madam, and your case of hydrocephalus, was it missed in antenatally using the ultrasound?
No, as I said,
they
did not do the, it was only last one ultrasound was done, which was showing a little bit of pleural effusion. The other things they could, because it was not, other things they did not pick up, and they did pick polyhydramnios.
Now, the case on PVC, you should have some kind of suspicion in the initial phase itself, and you should have given proper advice to the cardiologist doing echo to specifically look for the venous drainage, pulmonary venous drainage. In fact,
we did.
And also, the respiratory acidosis was prominent and not typical of PPHN and the investigations.
Yeah, that's why we did 4-time echo to say
also,
that.
Also, X-ray was not that it was somewhat atypical. X-ray also.
Yeah, that's why we asked for 4 echos, to asking for it, and this was being missed. even I mean, these because little bit of different presentation, we need to keep our eyes. That's the reason I'm just gave these cases to
That
when
is
to
true.
suspect and when to
Very
go
often
ahead
we
for
can
it.
use that
Yeah.
PVC, and of course, very difficult.
Yeah. And because it was not a total abnormality, it was just a partial one. And not only that, there was an arterial abnormality also. That's why it was a bit of missed.
Monica, thank you. In fact, what I enjoyed most is the cases were presented as managed, and that is why to a listener, they might feel that they were more challenging than they really were. But in reality, this is what happens, and a good presentation includes true, honest sharing of the experience that you went through. All the cases are unusual, and I think even if we were to face the same baby again, we would have challenges, especially if you look at chylothorax in maybe last 20 plus years, we might have seen some 15 cases. But each time you go through a, a challenging journey as to how to control it. In one baby, we learned about 10 years back that when we went to very high doses of octreotide than that was recommended in the literature, suddenly a 2 weeks or 3 weeks of chylous drainage stopped. And next time we decided to not go up in escalating doses as described in literature, but use a very high dose straight away at start go. And we have started using maximal doses of chylothorax of octreotide recommended in newborn practice as the starting medication. And in the last 5 cases, we found response within 1 or 2 days. But it is too short an experience to make recommendations that this should be the way we practice, because each chylothorax is different. And we do not know whether the brisk response was because of using higher dose and de-escalating, or because it was that babies were different. But maybe as a shared experience, some people, some of our colleagues who may be struggling with a baby may use very high doses. On the comments on diet, what we have found that even though we have tried restricting diets, they sometimes don't do enough. But what works is the octreotide, and somehow putting a baby on exclusion diets when breast milk is not a part can have other long-term implications. So this is just my feeling.
Yeah, we do like mix and then start a mother's milk as well, because we can't just get away from we can't like deprive the baby from the mom's milk. So we do give that, and that's the reason I think it took little more time for us to resolve it. And when you're working with many people to give octreotide, not to give octreotide, it becomes baby is improving, or by keeping and not giving the other kind of milk. So let's wait. That kind of things come in. So yeah, that's why I was just I gave this because they were a little challenging and little offbeat. But then just to make us awaken that we must keep our eyes and brain open. So what the brain will know, then only we would be able to try to look for it.
Any more queries? If there are
Madam,
no,
very excellent presentations of the case discussions. Very informative. Thank you so much.
Thank you. Thank you so much.
over to Sunda for the vote of thanks.
Thank you, Lens. So may I start by thanking our NNF Kottayam President, Dr. Joseph Patani sir, for presiding over the meeting. This is the second episode of NeoLect. May I also thank Dr. Naveen Jain sir. So much has already been spoken, and I'm not sure what to add, except to say that as an NNF and IAP Kottayam member, so we're very happy to have you associate with us during one of our meetings. Thank you so much. Thank you also, sir, for those pointers and for that extremely important point of how it is not easy to handle challenges cases where the whole scenario doesn't unfold in 5 minutes. It probably happens over weeks. And so thank you for giving us all those pointers. May I also thank Dr. Monica, ma'am. Ma'am, despite those challenges that you had with the logistics and with the climate issues, you've delivered an excellent talk, ma'am, for us, and you took us through 4 to 5 really challenging cases. And I think the point where you told us to keep our brains open is something that has that really makes sense. And with the pointers, I'm sure that we will definitely try to keep our brain open. Thank you so much, ma'am. And may I thank Linz and the organizers for keeping NeoLect going. I would like to say that this is a successful program because we have had nearly 100 participants over the last 2 sessions. Also, thank you to all our senior members, all our friends for logging in. Thank you all so much.
Thank you. Thank you for invite. Thank you so much. It was a nice meeting all of you. Bye-bye. Good night.
Good night. Good night, Monica.
Good night.